Welcome to the Radiology Advances podcast. Today we're tackling a big clinical challenge: how to accurately and automatically measure abdominal fat in children using MRI, and why that matters for metabolic risk.
The paper is Cross-cohort Federated Learning for Pediatric Abdominal Adipose Tissue Segmentation and Quantification using Free-Breathing 3D MRI, published in Radiology Advances in 2026. It's led by co-first authors Wenwen Zhang and Sevgi Gökçe-Kafali, with senior and corresponding author Holden Wu, all from UCLA's Department of Radiological Sciences.
And the core problem they're solving is this: visceral adipose tissue, or VAT. That's the metabolically active fat deep inside the abdomen. It's strongly linked to insulin resistance, dyslipidemia, and fatty liver disease, and often independent of BMI.
Right, you can have a metabolically unhealthy child with a totally normal BMI. And on the flip side, a metabolically healthy child with an elevated BMI. It all comes down to that specific VAT distribution. And BMI alone just can't distinguish between lean mass, subcutaneous fat, and visceral fat.
So to actually quantify it, you need MRI. But manually segmenting VAT on every slice is unbelievably labor-intensive. MRI datasets are notoriously small. That's the challenge this team set out to solve.
And it's worth setting the stage with the clinical reality they're up against, because VAT is not just a simple blob you can easily draw a circle around. It's an incredibly complex anatomical structure with highly variable distribution across different individuals.
Especially when you are dealing with a cohort of kids aged 6 to 18, you're looking at a dynamic, rapidly changing anatomical landscape.
Yeah, their bodies are growing, their fat distribution is actively shifting, and then there's the imaging physics problem.
Right, because kids squirm. As any pediatric radiologist listening knows, they do not just lie perfectly still inside a loud claustrophobic tube.
Exactly. Standard adult protocols for measuring abdominal fat usually use a breath-held Dixon MRI. You tell the adult to hold their breath, you snap the image, and you get a crisp picture with no motion artifacts. But you really cannot reliably ask an anxious 6-year-old or even a 12-year-old to hold their breath perfectly for that duration.
So, to prevent those motion artifacts, the clinical team used a free-breathing 3D stack of radial 6-echo Dixon sequence. Instead of reading data in K-space using neat parallel grid lines, which get completely disrupted by breathing motion, a radio acquisition reads data like the spokes of a bicycle wheel. The center of K-space, which holds the most crucial image contrast, is massively oversampled, making it inherently resistant to motion blurring.
And the 6-echo Dixon part is equally critical. Fat and water molecules resonate at slightly different frequencies in the magnetic field. So by capturing the signal at 6 different echo times, the researchers can mathematically separate the fat signal from the water signal, creating 5 distinct maps: opposed phase, in phase, pure water, pure fat, and the proton density fat fraction maps.
But this free-breathing sequence is fundamentally different from standard adult protocols. So standard adult deep learning models just don't map perfectly onto these pediatric scans.
And to make matters worse, pediatric MRI datasets for this kind of high-quality imaging are notoriously small. This specific pediatric cohort only had 134 children. In the world of 3D neural networks, that is a tiny training pool.
If you only train a standalone model on 134 kids, it suffers from severe overfitting. It basically just memorizes the anatomical quirks of those specific kids and struggles to generalize when it sees a new patient with a slightly different body habitus.
Exactly. The researchers clearly needed more data. They had a large multi-center adult data set of 920 overweight subjects from the habitual diet and avocado trial acquired across 5 centers and 7 different scanners. But medical data is heavily siloed. IRBs, data use agreements, strict patient privacy regulations. You cannot just move the actual patient data to combine it.
So the data can't move. How did they get around that?
Federated learning. Instead of moving the data to the model, you move the model to the data.
Tell us about the architecture.
They set up 2 local clients using NVIDIA's Federated Learning Framework, NV-FLAIR, one for the pediatric cohort and one for the adult cohort. Each client trained a 3D N_UNet model exclusively on its own local data.
So each site trains independently.
Exactly. Each local model looks at its own MRIs, makes segmentation predictions, calculates its errors, and updates its internal parameters. The actual patient data never leaves its home environment.
So what
What
gets shared?
only condensed model parameters, specifically the encoder weights. The encoder is the part of the neural network that extracts the high level structural features of human adipose tissue. That gets sent to a central server, which averages the updates and sends back a smarter global encoder.
But earlier you emphasized that the adult data was breath held and the pediatric data was free breathing. If you're aggregating model weights together, doesn't the global model get confused by those different acquisition physics?
It would, and this is where the researchers made a critical architectural decision. They only shared the encoder. The model adapters and the decoders were kept strictly local. So the encoder learns the universal language of what human adipose tissue looks like from the combined training, but the local decoder stays perfectly tuned to the specific MRI physics of each cohort, whether that's radial free breathing or standard breath held.
Now, does this collaborative model actually outperform a model trained solely on the local pediatric data?
First, the researchers ran ablation experiments to see which combinations of MRI series worked best, and all five together gave the highest performance. So, when they applied the FL1 model using all five series from both cohorts, the results were striking.
What did they see?
The FL1 model achieved mean DICE scores of 91.09% for visceral adipose tissue and 95.55% for subcutaneous adipose tissue. Crucially, it significantly outperformed the standalone pediatric model for VAT segmentation, with a p-value of less than 0.001.
And how did it compare to a jointly trained model that had full access to all the data, pediatric and adult combined?
No significant difference. The federated model performed comparably to joint training for VAT, with a p-value of 0.21, meaning they achieved essentially the same accuracy without ever sharing a single DICOM file.
Okay, but a high dice score is a computer science metric. How does that translate to actual clinical volume?
They evaluated the interclass correlation coefficients, or ICC, measuring absolute agreement between the model's volume estimation and the human expert's reference. The FL model hit an ICC of 0.99 for VAT and 1.00 for SAT.
Near perfect agreement on actual volumetric data. And what about the fat composition, the PDFF?
They used bland Altman analysis. The mean difference between the model and the human expert for VAT was just 0.21%. For SAT, it was negative 1.19%.
So the AI is producing essentially the exact same volumetric and compositional data as a highly trained human who spends hours meticulously tracing individual slices.
And the inference time? 2.84 seconds per subject. That means volumetric and PDFF data for a child can be calculated in the background while the scan is finishing and dropped directly into a structured report with zero added interpretation time, which fundamentally changes the game for longitudinal clinical trials.
Exactly. If you're testing a novel pharmacologic treatment, say a GLP-1 receptor agonist, in a pediatric population, you can now rapidly and objectively track minute changes in visceral fat volume over time across hundreds of patients.
Without burning out your radiology department.
Now, I do want to ground these results for a moment by looking at an edge case. The authors highlight an extremely lean 13-year-old girl with a BMI at the 6.5 percentile. The FL model's VAT dice score dipped to 78.38%, the lowest in the testing set.
This actually highlights a known mathematical property of the DICE coefficient rather than a failure of clinical utility. In very lean patients, the absolute volume of visceral fat is tiny, maybe just a few voxels wide in certain areas. If the segmentation boundary is off by 1 or 2 pixels, the percentage overlap drops precipitously, even though the actual volumetric error is negligible. The regression analysis in the study confirmed that model performance naturally correlates with BMI.
A great reminder that we can not just look at percentage metrics in a vacuum without understanding the underlying mathematical math. So, to summarize for the clinicians and researchers tuning in, We now have a validated sub-3-second automated tool to quantify cardiometabolic risk in children.
And it successfully overcomes the anatomical challenges of pediatric growth, accommodates the physical necessity of free breathing radial MRI protocols, and completely bypasses the massive logistical hurdles of institutional data sharing.
Definitely a great step forward. We're coming to a close of today's Radiology Advances podcast. Thanks to Zhang and colleagues for their work published in Radiology Advances. If you found this episode informative or have any other feedback, please rate, review, and subscribe. It helps more people discover the podcast and supports the broader conversation around innovation in imaging. You can read the full article and explore more great content on the journal website. This episode was generated with the help of AI, but all content was reviewed and verified by editor Dr. Nelson Gill from Massachusetts General Hospital for accuracy. Thanks for joining us.